Hello, welcome to our Women's Health Update on postpartum depression. I'm Arefa Cassoobhoy. Today I'm joined by Dr. Elizabeth Fitelson. She's at Columbia University, where she's director of the Women's Program in the Department of Psychiatry. What differentiates the baby blues from postpartum depression, and how common is it for women to experience depression for the first time during that postpartum period? Is there a time during that first year that women are most vulnerable?
So when you look at rates of women who have perinatal depression or postpartum depression, most of those depressive episodes actually start before or during pregnancy. So about 25% of women will have pre-existing depression, and they may in fact have been depressed at the time they got pregnant. Another third will get depressed during the pregnancy, and then about 40% actually have depression that starts in the postpartum period. Technically speaking, according to DSM-5 criteria, something is a quote-unquote perinatal depression if the depression starts during pregnancy or within the first 4 weeks postpartum.
Okay.
Most experts in the field who treat women consider it to be postpartum depression up to a year postpartum, or even longer if the woman is lactating.
Do you recommend screening all new mothers for depression?
Yes. So there have been new guidelines put out that recommend screening for all women during pregnancy and the postpartum period for depression.
What tool do you like?
So the Edinburgh Postnatal Depression Scale is probably the best validated scale for perinatal depression because it focuses on the mood and anxiety components of perinatal depression rather than the somatic symptoms. If you think about the criteria for major depressive disorder, in addition to low mood and loss of interest in things, there's a lot of somatic symptoms that go along with depression, like changes in sleep, changes in appetite, changes in energy, changes in libido, which are all perfectly normal parts of pregnancy and the postpartum period, as anyone who's had a child can tell you. However, the PHQ-9 has also been validated in the perinatal period, and in large healthcare systems, for example, that are already using the PHQ-9 in other settings in the primary care setting, it may in fact make sense to use the PHQ-9. You just vary the cutoff.
Who are the women most at risk that we as doctors should recognize or kind of take note of?
So certainly women who have a pre-existing depressive or anxiety disorder, women or carry another diagnosis such as bipolar disorder or are in treatment. There's also some evidence that women who have mood sensitivity around their menstrual cycle may be at more risk for postpartum, for perinatal depression and anxiety.
Because of the hormone shifts?
Yeah, there seems to be sort of a cohort of women who have a particular hormone sensitivity. Not every woman has significant mood sensitivity with their hormones, but there probably are some women who are more sensitive to those shifts than others, and that might be a risk factor. Other risk factors for perinatal mood and anxiety disorders include having an unwanted pregnancy, low social support, financial stressors, medical complications, a history of trauma, intimate partner violence, including during pregnancy, which is unfortunately more common than we would like to think it is.
Right.
And losses, obstetrical complications, or a complicated delivery.
What are the main treatment options available, and how safe are these for breastfeeding mothers?
The mainstay of treatment for perinatal mood and anxiety disorders, especially for mild to moderate, is psychotherapy, enhanced support, practical emotional supports, good nutrition, good care, exercise, getting out. Our first line treatments, and what we should all be advocating for, is for everyone to have better access to good psychotherapy, evidence-based psychotherapy, such as interpersonal psychotherapy or cognitive behavioral therapy for women in the perinatal period, as well as for interventions that help enhance support. Also for vulnerable women to give them the time to stay home with their babies that they need to really recover from the experience. From a pharmacologic point of view, because so much of perinatal depression is comorbid with anxiety disorders, anxiety really can be the presenting problem for many women.
Sure.
SSRI antidepressants tend to be the first line treatment in terms of medications. So, sertraline, citalopram, escitalopram, fluoxetine, those have been around a long time. There's a good amount of data on them. SSRI antidepressants in general have fairly low passage into breast milk.
Okay.
And the American Academy of Pediatrics does not think that they're contraindicated in breastfeeding. So most women who are on an SSRI antidepressant can breastfeed successfully.
And I imagine for women you're seeing that are at high risk for postpartum depression, all the non-pharmacological therapies that you just mentioned, how successful do you think they are for preventing that dip into depression?
It really depends. So if she's someone who's had anxiety and depression most of her life, has been through different therapies, has tried different medications, I try to work with her to see what can we do that's going to maximize our non-medication interventions, but then use sort of rational decision-making around using medications when we need it. So I definitely think, there should be more access to psychotherapy, but it doesn't work for everyone. Okay, and there shouldn't be shame in having to take a medication.
So people seem to be familiar with the baby blues and postpartum depression. They're not as familiar with depression during pregnancy. Do you recommend screening for pregnant women for depression?
There is greater recognition now that most postpartum, quote unquote, depression actually starts during pregnancy. It's important to recognize depression in pregnancy, both to prevent the postpartum depression, but also to help women recover during their pregnancy for many reasons. One, depression is terrible. There's so much suffering involved with depression. And it's really important to help our patients feel better, especially at this time, which is so important, so vulnerable. And really women want to go into parenthood feeling as strong and well as possible. And that's good for them. It's good for their partners. It's good for their family. It's good for the baby. We also know that untreated depression and anxiety disorders have an impact on the pregnancy. Anyone who's experienced anxiety or depression can tell you it's not all in your head.
Yes.
These are conditions that affect, the mind and the body, and mediated perhaps through things such as increased cortisol levels. Cortisol is a stress hormone. In depression and anxiety conditions, cortisol levels are high and stay high and don't sort of vary as they do normally through a day or in response to stress. And, a fetus developing in the context of high cortisol levels, there's changes that happen in the placenta and the fetus. I'm not saying all those changes are necessarily bad, but it has an impact.
You and I talked earlier about considering a woman with mental illness as having a high-risk pregnancy. Yeah. And so how does that, for OBs that are watching, how should this change their management and caring for these women?
I think people get focused on, do we medicate or not for these conditions? And that tends to be where a lot of the research is, where all the studies coming out, and the concerns tend to be about the risks of medication and pregnancy.
Yes.
And there's fewer concerns about the risks of untreated depression and anxiety in pregnancy. And when you step back from that and actually look at the cohort of women with depression and anxiety diagnosis, or actually any psychiatric diagnosis, this is a high-risk group of women. So if you look at pregnancy-associated deaths, so to use an extreme example, and one that's been in the news recently, Massachusetts actually just came out with a report on pregnancy-associated deaths in, I think 2014 was the last year the data was available. And over half of the women who died in pregnancy or within the first year postpartum had a pre-existing psychiatric condition that may or may not have been directly related to the cause of their death. But many of these women died from obstetric complications such as hemorrhage, preeclampsia, et cetera. A significant portion died from substance-related issues or suicide as well. But having a mental health diagnosis actually does put women into a higher risk category for perinatal morbidity and mortality. And so my opinion is that these women should be seen in the higher risk category, whether or not they're on medication.
Well, that sort of feeds into my next question about talk therapy as a cornerstone sort of of treatment, especially during the pregnancy period. What do you recommend for those with a lack of access to specialists like psychiatrists and psychotherapists? I know out in the community, some women may not be able to have access. What other options are there, like telemedicine?
I think that the emergence of telemedicine is actually really exciting in terms of accessing women, perinatal women, and offering them high quality treatment, because women are so isolated in the postpartum period, even in the best of circumstances. I found in my practice, we have some, at Columbia, we have some telemedicine capabilities that actually telehealth visits have been really great for working with perinatal women, because you both have better access. They can, even when they don't feel like they can leave the house yet with the baby, you can have a session, you can check in on them and have a real conversation about what's going on. And as a clinician, I can sort of get a little bit of a snapshot of what home life is like and what they're, you know, how they're interacting with the baby and in their own environment where they're more comfortable. I'm not saying that that's a substitute for in-person treatment. I would never advocate for that as a replacement, but certainly in terms of access during the perinatal period, I think telemedicine is actually a really good option.
Are there other non-medical options that you recommend for prevention or treatment?
Whenever I'm counseling a woman or a couple about who's at risk for perinatal mood and anxiety disorders, the things I like to talk about the most are practical and emotional supports.
Okay.
So there was one qualitative study, I think it was done in Texas, I can't remember exactly, but they asked women who had recovered from postpartum depression, what were the most important factors in your recovery? And I think the top 4 factors were emotional support from my partner, practical support from my partner, practical support from my family, and emotional support from my family. And any sort of psychiatric intervention was way down the list. So I always think about that. And support is really the name of the game in that period of time, both because of the isolation that can happen and the sense of, you know, women get isolated and there's so much shame around feeling bad during this period. There's almost, you know, even though we've had so much progress in talking about perinatal depression and anxiety disorders, there have been some courageous celebrities who have come out, some courageous non-celebrities who have come out and talking about their experience. I think women still feel like it shouldn't happen to me.
Yes.
And I should be able to get through this. I shouldn't be feeling this way. And so it's so incredibly painful and shameful to be feeling so badly, or to be having what is often intrusive thoughts about something terrible happening to the baby, or even doing something terrible to the baby. Even in women who would never in a million years actually be at risk of harming their baby, these thoughts can be really torturous. And so there's such a barrier to actually, you know, saying anything about it. So anything you can do that reduces isolation in terms of support groups can be very powerful just for that reason, because once you start actually opening up a little bit about your experience, you will absolutely find other women who will say, oh yeah, I went through that. It was terrible. Right. And you're like, well, why didn't you tell me that before? Why didn't anyone tell me? For more severe depression and anxiety disorders, you know, some women, there's been some studies looking at transcranial magnetic stimulation, TMS, which is a newer technology that was developed as an alternative to electroconvulsive therapy, ECT. So there's some studies about that for more significant depression, anxiety disorders. So there's actually a whole range of non-medication options that are available to women, or should be available to women, I should say.
Well, thank you so much, Elizabeth, for joining me today.
My pleasure.
For those of you in the audience, send us your comments. So we'd like to hear back from you.